Now, the next speaker is Dr. Fouad Abo Hamila, Professor of Obstetrics and Gynecology, Cairo University. The lecture by name of freeze-all strategy, which indication.
صباح الخير. اولا انا بتشرف ان انا موجود النهارده في مؤتمر القصر العيني، وبتشرف بوجودي مع حضراتكم، وان انا البرزنتيشن عن الفريز اول استراتيجي، وبتشرف ان انا بدي محاضره بعد فينويلي، الدكتوره فينويلي طبعا دي زي محمد صلاح كده في الكوكرين ريفيو، وبأشرف برضو ان انا بدي محاضرتي قبل استاذي الدكتور حسن المغربي، القامه الكبيره في طب اسكندريه، وبتشرف ان هو موجود معانا النهارده. خلاص، وهحاول ان انا ما اعيدش الكلام لان في كلام اتقال وفي كلام هيتقال، فعشان ما اطولش على حضراتكم. The use of frozen embryo transfers has steadily increased over the past decade, and this approach to ORT is now practiced worldwide. انتشرت الفروزن embryo transfer cycles زي ما احنا ما شايفين في الكيرف in the past decade. زيادة في الفروزن embryo transfer cycles, decrease in the number of the fresh embryo transfer cycles, and this tendency may be attributed للdevelopments in the cryopreservation techniques. الvitrification طبعا أفضل من slow freezing technique, generation less, والtendency to decreasing the number of embryos transferred to decrease the incidence of multiple pregnancies, and the more towards the elective single embryo transfer. The current trend, however, is not to freeze the extra embryos, but to freeze the entire embryo cohort اللي بيقال أو بيسمى deferred embryo transfer أو freeze all policy. The hypothesis with ovarian stimulation, as seen in this chart, there is a tendency to increase in the estradiol level, which is maximum before the HCG trigger. And this supraphysiologic level of estradiol may have implementary effect on the histological, immunological, and genetic changes, leading to may affect the implantation. So it has been hypothesized that implantation rates could be improved by transferring in another more physiological cycle. Options for frozen cycles may be a natural cycle in case of ovulatory patients, mild ovarian stimulation with letrozole, or artificial programmed cycle with estradiol, valerate, and progesterone. The three methods were considered equally successful, nearly successful in terms of live birth rate. However, the details will be addressed in more details by Professor Hassan al-Maghrabi. What are the indications of the freeze-all policy? There are two strategies, either a rescue strategy or a schedule strategy. Rescue strategy, we mean that we take the decision to freeze all during the ovarian stimulation cycle, mostly known in cases of risk of OHSS. Other applicable indications that may be considered, like inadequate serum progesterone level, endometrial causes, and embryological causes. As we all know, the risk of OHSS can nearly be prevented nowadays by the antagonist protocol and triggering by the agonist, and this will prevent early hyperstimulation, and by freeze-all policy, you prevent late hyperstimulation. While in cases of the agonist protocol, the freeze-all policy will decrease the severity of the hyperstimulation, not totally eliminated. So findings suggest, as was presented in the previous lecture, that freeze-all approach is optimal strategy for patients of PCOS at risk of hyperstimulation. And this was presented by Peter Hamaidan et al. In the systematic review and meta-analysis. This slide was presented in the previous lecture. Definitely there is a benefit in the freeze-all strategy to decrease or to abolish or decrease the severity of hyperstimulation more than the fresh embryo transfer. Although this slide also was presented in the previous study that there was no effect nearly on the cumulative live birth rate or the live birth rate in the normal IVF population. So correctly or collectively, the current evidence suggests that elective frozen embryo transfer is superior to fresh embryo transfer in terms of reducing the risk of hyperstimulation on both normal responders and actually hyper responders subjected to HCG trigger. What about inadequate serum progesterone? Most of the talk is the high level of serum progesterone. Elevated serum progesterone happens in the late follicular phase before the trigger. Data is variable about what is the optimal level we consider. Some considered low as 0.08 nanogram per mil, others 2 nanogram per mil or 2.5 nanogram. And this may lead to what we call advancement of the endometrium and asynchrony between the embryo and the endometrium. So a rescue freeze-all policy can be an option to avoid this determinal effect on the endometrium and implantation. And this was also shown by some studies. On the other hand, what is not more common to talk about is the low serum level of progesterone. There are 2 or 3 observational studies that address this topic, and they indicate and they showed that if there is a low level of serum progesterone, less than 0.5 nanogram at the day of the trigger or less than 18 nanogram at the day of transfer, this will lead to a lower live birth rate. However, no RCTs, so caution should be needed to interpret these studies. Uterine causes as a routine before the starting of the induction of the ovulation and, or IVF procedure, we should evaluate the uterus, whether by 3D, sonography, or diagnostic hysteroscopy. So most actually abnormal anomalies in the uterus, they can be detected before starting the ovulation. However, in some cases, eventually adverse side effects appear or adverse abnormalities appear, like thin endometrium during ovarian stimulation or endometrial polypi. And it should be considered in these cases to freeze the embryos, not the transfer in the same cycle. As we all know, thin endometrium, less than 7 or 8 millimeters, may affect the live birth rate. These are some anomalies that could be evaluated, whether before or during the stimulation. Embryological causes, it is always known that transferring day 5 blastocyst is superior to transferring day 6 blastocyst. So if there is a delay in the development of the embryos, it is better apply a freeze-all policy to prevent the embryo endometrium asynchrony and to freeze the embryo in the blastocyst stage and to transfer it to another stage. What about the other strategy, the scheduled strategy? By scheduled strategy, we mean that we decided before the start of the cycle to freeze the embryos and not to transfer. This is before starting of the cycle. And this can be applied particularly in patients undergoing pre-implantation genetic testing. Other indications may be considered, like some considered in cases of endometriosis, adenomyosis, repeated IVF failure, and this will be addressed by my colleague Mohammed Abdel Fattah, and the risk of thromboembolic diseases. PGT, the ISHRI PGT Consortium Committee 2020 has said that patients undergoing PGT, whether for aneuploidy screening, monogenic diseases, structural rearrangements, embryo biopsy can be done at any stages, but particularly better in the blastocyst stage. Embryos are vitrified, and we do a transfer in another cycle after the results of the genetic testing is applied. This will be a better outcome as presented by this RCT by Coates et al. 2017 infertility sterility, showing that this will give a higher live birth rate. Endometriosis is a bit debatable. It is hypothetically assumed that endometrial receptivity can be disturbed in endometriosis patients after ovarian stimulation. So it is suggested that in cases of endometriosis, particularly in repeated failure, we can freeze the embryos. We do a down regulation by GnRH agonist for 3 months or Dienogest 2 milligram for 3 months before attempting to transfer the embryos in a frozen cycle. That may give a better result. The same applies to adenomyosis, or the less data are available, and the same protocol can be applied in cases of repeated failure in adenomyosis, or without repeated failure, you can freeze the embryos, go down regulation with agonist pre-treatment or Dienogest pre-treatment for 3 months, and then do a frozen embryo transfer, may have a positive effect on the chances of pregnancy. What about repeated IVF and ICSI failures? I will not go in this because this will be addressed, as I told you, by my colleague Mohammed Abdel Fattah by his magnificent work. Freeze-all could provide a more physiological environment for the embryo transfer than improving implantation. However, the results are a bit mixed due to the heterogeneity in the definition of the repeated implantation failure between the various studies. Some advocate that freeze-all can be a superior therapy to another fresh cycle in patients with prior fresh blastocyst implantation failures. Others have advocated that the deferred embryo transfer, what we call the freeze-all policy, seems not to be as good option after repeated failure. So actually, it is a bit debatable. What about the risk of thrombosis? Frozen embryo transfer, it replicates nearly the same hormonal and coagulation state of natural conception. On the contrary, with the fresh embryo transfer and the supraphysiologic level of estradiol, this will increase the acquired resistance to the anticoagulant action of activated protein C. So it seems wise enough, as according to a nationwide cohort study that was published in the Journal of Thrombosis and Hematology. This was a large Swedish study presented by Nina Olsen in 2020. From 1992 to 2020, they compared the risk of venous thromboembolism and pulmonary embolism after natural conception, after fresh embryo transfer, and after frozen embryo transfer, starting from pregnancy till 6 weeks postpartum. And they showed that there is an eightfold increase in patients of fresh embryo transfer in the risk of venous thromboembolism than in natural conception and frozen embryo transfer. But to be honest, most of the cases where high estradiol level was detected, and they attributed this to high estradiol level that may result in cases of hyperstimulation. So a freeze-all policy could be an option in patients with risk of thrombosis. What about the safety as regarding obstetric and perinatal outcome? Factors influencing the pregnancy outcome include maternal characteristics, ovarian stimulation protocols, luteal support modalities, the technique of the cryopreservation itself, the number and stage of embryos transferred, and the protocol of the endometrial preparation and the frozen transfer. And I think this will be addressed by Professor Hassan al-Maghrabi. According to the miscarriage rate, no difference was found between the freeze-all strategy and the fresh transfers. Preterm delivery, no difference in the risk of delivery before 33 weeks of gestation. Fetal growth and birth weight, as addressed in the previous lecture, most studies have revealed a higher risk of low birth weight and small for gestational age in the fresh transfer. And low birth weight, this may be attributed again to the supraphysiologic level of estradiol, leading to alternation in the endometrial receptivity, leading to an abnormal implantation with the increased risk of ischemic placental diseases. On the contrary, large for gestational age has been found to be more with the frozen embryo transfer cycles, and this was addressed in the American Journal of Obstetrics and Gynecology. And potential effect of the vitrification process itself and the thawing process may lead to fetal development due to possible epigenetic changes. So fetal macrosomia and large for gestational age may occur more in the frozen embryo transfer cycles, but I confirm a bit on the hormone programmed cycles, not on the natural cycles. Gestational hypertension, the same. Several studies have shown an increased risk of hypertensive diseases and preeclampsia in the freeze-all cycles, higher incidence in the programmed cycles due to the absence of corpus luteum. In these cycles, there is no ovulation, and the corpus luteum is not just a role of producing progesterone for luteal support, but it produces androgenic factors and immune regulatory factors that may affect the implantation. While on other obstetric and prenatal outcomes, there was no marked difference as reported with other pregnancy outcomes as regard the gestational diabetes, antepartum hemorrhage, congenital anomalies, and perinatal morbidity. What about the long-term health outcomes? Few available data has been published are reassuring. Physical, mental, and most health indicators are nearly similar as regard the fresh and the frozen embryo transfers. What about the cost effectiveness? And this is an issue that should be considered, particularly in Egypt. Currently, few studies have evaluated this issue, which is highly challenging as it requires integrating multiple parameters. What advocate the freeze-all policy that does drastic decrease in the rate of OHSS, so this will lead to a decrease in the cost in the medications and the admission to intensive cares and the cost of treatment. We can apply, according to Pilots 2018, a more aggressive ovarian stimulation, more oocytes, more embryos that will lead to a higher cumulative live birth rate and a potentially lower risk of low birth weight. However, there is a need for additional treatment for endometrial preparation, the use of the additional cost for the preservation techniques, and this should be very well considered in Egypt. And there is no public funds here. And few studies have reported an increase in the time of pregnancy. The time of pregnancy, where a few studies have focused on this issue and reported there is an increase in the time of pregnancy in the freeze-all strategy, and this may add a psychological burden for the patients. What about the live birth rate? The results, they fail to demonstrate any advantage of the freeze-all strategy in the overall IVF population. Recent meta-analysis, including 5 RCTs, showed there is no significant difference in the cumulative live birth weight, again in the overall IVF population. However, a potential benefit was highlighted in the high responders. Clinically, if you consider the freeze-all strategy, or in the cases of definitely the pre-scheduled cases, We may consider the antagonist protocol in these particular cases because it has the flexibility of using the agonist trigger. The transfer of frozen embryo transfer can be carried out as soon as the first cycle. We don't need to wait for 3 months or 4 months after ovarian stimulation without negatively affecting the chances of live birth rate. Available data, they tend to indicate that definitely the blastocyst stage is more superior compared to the cleavage stage in the frozen embryos. Vitrification is clearly more superior than the slow freezing. There is no specific protocol for endometrial preparation is more superior. However, we should consider the perinatal outcome and the perinatal morbidity, and particularly in the patients, as regarding whether to apply the natural cycle or the simple stimulation or the HRT program. Recent meta-analysis showed that there is no significant difference between fresh and frozen embryo transfer in the cumulative live birth rate, and this was presented in the previous study. A potential benefit of the freeze-all policy in the cumulative live birth rate may be found in high responders. On basis of these findings, it seems inappropriate, in my opinion, my humble opinion, to implement freeze-all strategy in all patients undergoing ART, which is a bit debatable, but this is my humble opinion. This, to sum it up, this schedule, according to a schedule strategy or the rescue strategy, based on RCTs, definitely in cases of pre-implantation genetic testing, in cases of risk of OHSS, other are optional and lack of strong scientific evidence, whether endometriosis, adenomyosis, elevated progesterone level, embryological causes, or in prevention of thromboembolic diseases. Thank you.
Thank you, Professor Fouad, for this presentation. To sum it up about the general policy of freeze-all in some centers, you kindly highlighted that this is still a place for more studies and controversies, so as not to adopt it as routine, because lately there have been some centers that adopt the freeze-all policy, some physicians adopt the freeze-all policy, apart from the extra cost that you kindly noted, but as per scientific evidence, this might not be 100 sound strategy. But the point that I want to come up from this session, because we have to come up with a message, the point that concerns me and is challenging for me is about the adenomyosis cases. So should we freeze all? And as you said, you give progesterone for 3 months, and then Professor maybe Hassan will show us after the 3 months or whatever policy you're going to follow for adenomyosis patients. Are you going to do a medicated cycle or non-medicated cycle? Will estrogen high doses activate the extrauterine adenomyosis sites, affecting chemically the pregnancy? It's a point that if we together reach this as a take-home message from this session, this will be very valuable, because for some reason or another, there are increased incidence of adenomyosis. We see it a lot with all its trouble, apart from other infertility problems. But having it as a challenge in IVF will need a general consensus policy for us to reach whether to transfer a fresh cycle, whether to freeze all and give medications. Depending on your preference, you're going to use the long protocol for suppression with the analog or not. It's different from one physician to the other, but if you, Professor Hassan, can highlight as well during your presentation, what do you do in case of adenomyosis, we'll greatly appreciate it. Thank you, Professor Fouad. Any more questions for Professor Fouad? Okay, thank you.